Hi everyone, we are going to see all the questions which were asked in a recent INI CET exam. And this time, most of the questions they have asked from psychopharma. Let's see all the questions one by one. First question, a 30-year-old male presented to hospital with altered sensorium and pinpoint pupil. Which substance intoxication is suspected in this case? So this is a question related to substance abuse. And when we see pinpoint pupil out of these four options, 100% answer is opioid, because in all other options there will be mydriasis. So whenever we see a patient after overdose of a substance where patient is presented with a CPR, if patient is in coma, if patient is having pinpoint pupil, and if patient is in respiratory depression, we can say that yes, this is a case of opioid poisoning. So what are other symptoms of opioid poisoning? Since it is going to cause respiratory depression, after that what is happening here? Yes, there will be low heart rate also, low BP and hypothermia, and there will be what? Pinpoint pupil. All these are the symptoms we see in opioid poisoning. So here the root cause of death is respiratory depression. Next important point, what is the drug to be used in a case of opioid intoxication? When overdose, then drug of choice is naloxone, IV injection, and this is actually having short half-life, only 30 minutes. But for the relapse prevention, which drug to be given? You have to give long-acting drug like naltrexone. Half-life is 96 hours. And for the withdrawal symptoms, we can use a long-acting opioid like methadone. So these are the points which you have to keep in mind related to opioid toxicity. And see, second question, a patient was started on TCA drug. Some students say name of drug was also mentioned, and this was amitriptyline. Alright. And was found to be unconscious. Which of the following is not suggestive of TCA toxicity? So basically this question is based on the case of TCA toxicity. These days, TCA is considered as a second line drug of depression. Why second line? Remember, TCA is going to block serotonin and norepinephrine both. So suppose if TCA is going to increase the level of serotonin and norepinephrine, fine for the patient will be happy. But apart from serotonin and norepinephrine, TCA is also antagonizing some receptors like muscarinic receptors, histaminic, alpha 1, alpha 2, sodium gated channel of heart, and metabolic acidosis it is causing. So see here, because of these receptors, yes, there will be so many side effects after TCA. Because of histaminic receptor, yes, patient will be complaining of what? Over sedation. Every time patient is sleeping, sedation. Because of alpha 1 receptor, patient is having what? Hypotension, severe headache, right? Because of sodium gated channel, patient is complaining of what? Arrhythmia. And finally, patient is causing what? Metabolic acidosis. What about muscarinic receptor? Because of this, yes, there will be what? Anticholinergic side effects also, like blurred vision, urinary retention. So see here, after seeing all these side effects, I can say that patient is having CVS side effects also, CNS also. CNS because of what? Increased level of serotonin. Yes, ANS symptoms also. CVS, yes, there will be arrhythmia. CNS, yes, there can be seizure also, mental confusion also. Now, ANS symptoms. See, remember here, because of the muscarinic receptor, now patient is complaining of what? Blurred vision, urinary retention, constipation, dry mouth, and patient will be having what? Mydriasis also. And after that, what is happening here? There will be what? Blockage of thermoregulatory sweating. So now temperature will increase. So there will be hyperthermia, not the hypothermia. So answer is D. So remember here, TCA is not very good for patient, but TCA is very good for medicos, because TCA toxicity and lithium toxicity, these are repeatedly asked questions in all kind of exam. So remember here, whenever there will be TCA toxicity, what are the investigations which are mandatory? Yes, ECG should be performed, ECG should be done, where there will be what? Increased QRS, PR interval, right axis deviation there. All right, we have to do ABG also, because metabolic acidosis. So how to treat the case of TCA toxicity? Remember here, most important thing is that here patient is having metabolic acidosis also. So remember, first line of management is what? Serum alkalinization. Basically we have to give what? IV sodium bicarbonate. IV sodium bicarbonate. We can also use the charcoal. So please remember, TCA toxicity is always an important topic for all the exams. So please go through this for NEET PG exam also. Next, lithium toxicity case. A pregnant female in third trimester who is a known case of bipolar disorder with previous history of 4 episodes visited a psychiatrist. She did not get any episode for last 1 year and she is well controlled on lithium 750 milligram. What is the next step in the management? Lithium toxicity. Let's understand some points related to lithium. Overall, lithium is the gold standard mood stabilizer, euthymic drug. At the same time, lithium is having very narrow therapeutic index. Because of this, it has so many side effects. Lithium can affect so many organs. Lithium can affect so many parts of the body. See, in CNS, what will be the side effects? Yes, this can cause coarse tremors. See, what about endocrino part? This can cause hypothyroidism. And when I talk about a renal part, yes, this can cause nephrogenic diabetes insipidus, because it will cause polyuria, which will cause polydipsia, and finally what? Diabetes insipidus. All right, but what about during the pregnancy? This is our question. Yes, lithium is also a teratogenic drug which can cause abstinence anomaly. Especially, lithium is more injurious during first trimester. But the question is, when we know this fact that lithium is a teratogenic drug, can lithium be used during pregnancy? Yes or no? Answer is yes. Yes, this can be used. Why? This can be used. Remember here, yes, it can cause abstinence anomaly, but ratio is very less, 1:1000. So yes, if it is needed, even during pregnancy, lithium can be used. So see here, in this case, patient is already on the lithium and patient is well controlled on a lithium. Now, what should be the next line of management? Are we going to switch to Valproate? Answer is no. Because if she is well maintained on lithium, what is the need of using Valproate? Because Valproate is also very dangerous during pregnancy. This can cause neural tube defect like spina bifida. So don't do this. Are you going to stop the drug? No, this is bad idea, because if you are going to stop the drug, this can cause relapse. So now what about, are you going to increase or decrease the dose? Remember, what are the changes? What are the physiological changes during third trimester of pregnancy? Remember, there will be increased GFR, there will be increased plasma volume. Remember here in third trimester, yes, now there will be what? Increased plasma concentration of lithium. All right, ideally, we should only monitoring the case, but it is not given in the option. So we have to choose either to increase the dose or to decrease the dose. When patient is already on the lithium during pregnancy, most important thing is what? To monitor, to adjust. Increasing the dose is not a wise decision because it can cause lithium toxicity for sure, right? No? So ideally we should be monitoring it, but we have to choose one option here. So yes, we should not be increasing the dose. Remember here, during the time of labor, we have to stop lithium. And after the delivery, we have to restart. This is the protocol. So remember here, out of these options, if we have to choose, remember here, better option will be decrease the dose. Answer should be decrease the dose. And what about during breastfeeding? Yes, lithium can be used even during breastfeeding, but with caution, because there will be more beneficial effects than side effects. So here, answer is D, decrease the dose. See question number 4, which of the following side effects is less commonly seen with carbamazepine than oxcarbazepine? Examiner is asking which side effect is less associated with carbamazepine and more with oxcarbazepine. As we have learned about carbamazepine, very, very important drug, yes, but this has liver toxicity as a side effect. This can cause Stevens-Johnson syndrome. And the grave side effects, obviously Stevens-Johnson syndrome is very, very serious, and grave side effect like aplastic anemia and agranulocytosis. Very, very important thing, agranulocytosis, where there will be destruction of WBC and neutrophils, and this can be lethal for the patient. That's why, see here, I have taught you when I was teaching about schizophrenia, where we were using a very, very important drug, second generation drug, clozapine. Even with clozapine also, what are the grave side effects? Granulocytosis, seizure, myocarditis also there. So remember, especially granulocytosis. So in this manner, we can understand that carbamazepine and clozapine should never be combined, because there will be what? Superimposition of granulocytosis, right? So remember here, so yes, this is also correct. Now, what about hyponatremia? Let's see this part. Whenever we are going to start the patient on carbamazepine or oxcarbazepine, we have to check sodium level, because do understand this. Okay, see the side effects of these drugs. When I talk about carbamazepine, yes, nausea, vomiting, diarrhea, and constipation, also drowsiness. These are very commonly seen with carbamazepine. Hepatitis, liver toxicity, yes. Very serious side effect is Stevens-Johnson syndrome. Granulocytosis, aplastic anemia, lethal. Okay. And now when I talk about oxcarbazepine, remember most common side effect is what? Nausea and what? Sedation. Remember, remaining other side effects we do not see here commonly, but hyponatremia, remember here, whenever we are going to start the patient on these drugs, we have to check sodium level of the patient, because hyponatremia is the side effect of these drugs. And remember here, hyponatremia is more commonly associated with oxcarbazepine. So answer is oxcarbazepine here, hyponatremia. See question number 5. First of all, consider the following statements. Here, this is about pre-contemplation, contemplation, maintenance, and action phase. Remember, see, these are the stages of changes when there is a substance abuser. So here we are going to understand the stages of changes. First of all, first stage is called about pre-contemplation, then contemplation, after that preparation, and then action, and then maintenance phase. Okay, so what is the meaning of pre-contemplation? When I see a substance abuser, and substance abuser does not find anything wrong with his habit, no problem at all, I'm okay. This is called a pre-contemplation phase. But contemplation stage means what? Where a person starts understanding that no, this is actually wrong. When he starts understanding, when he accepts that this is wrong, this is called as contemplation phase. And after that, next stage is called a preparation phase, where he wants to meet a clinician. And when he will be started on medicine, this will be called as action. After that, he has to maintain the abstinence. So these are the stages of changes. So see here, option number 1, pre-contemplation, a person who smokes is considering to quit smoking. No, this is actually wrong statement. Pre-contemplation stage, person does not find anything wrong. Contemplation, a person is considering to start morning walks because of its benefits to the health. Yes, this is actually right. Yes. Maintenance phase, a person has quit smoking for 1 year and has not smoked since then. This is also correct. Action, a person with obesity says he cannot do anything as it runs deep in his family. No. So out of these 4 options, which statements are correct? Option number 2 and 3. Next question. Say question number 6. An elderly patient with Alzheimer's disease is not able to tolerate medication orally. Which of the following acetylcholinesterase inhibitors can be used? So examiner has specially mentioned here acetylcholinesterase inhibitor. So out of these 4 options, when you see option number B, this is NMDA antagonist. So this we can easily rule out. Now donepezil, rivastigmine and the galantamine. Okay, fine. See the drugs here when I talk about acetylcholinesterase inhibitors. Remember, like donepezil, rivastigmine, galantamine and tacrine. These days we are not using tacrine because of so much of the side effect, because of what? Hepatotoxicity. So out of these drugs, when patient does not want to take medicine orally, see here why he is not able to tolerate, because of the side effects, because of GI side effects and all. So yes, if patient is not comfortable there, then we can use a medicine which can be given as a dermal patch, right? So remember here, out of these drugs, which medicine can be given as transdermal? Remember here, especially rivastigmine. Okay, fine. But these days we should know this fact that even donepezil, this is also available as transdermal, right? But this is actually recent. So suppose if we have to mark one answer, then we should go with rivastigmine. Answer is D. Means if we have to choose one option, it should be D. At the same time, let's know about some important drugs, some other drugs, some new drugs like monoclonal antibodies for Alzheimer's, dementia, okay, like aducanumab and lecanemab. These we are using as IV injection. Now, last question. A bipolar patient on mood stabilizer has developed hyperammonemia and raised hepatic enzymes. Which of the following drugs is likely to cause these symptoms? Basically, examiner is asking about mood stabilizer which can cause hyperammonemia and what? Liver toxicity. So yes, we have learned very much frequently in psychopharma about Valproate, right? Very, very important. Remember here, when I talk about this drug Valproate, what are the side effects? First of all, we should know that this will be having what? Liver toxicity. Liver toxicity. And this liver toxicity can be lethal if the patient age is less than 2 years. Means in a pediatric age group, hepatotoxicity, yes, this can be lethal. Yes, this also causes pancreatitis. Pancreatitis. Remember here all these points. And at the same time, you should also know this fact that when I write here, hyperammonemia. Yes, this can cause encephalopathy. Encephalopathy. This is also a teratogenic drug. So, what it can cause during the pregnancy? Remember here, Valproate should never be tried during pregnancy because this can cause neural tube defect. Which neural tube defect? Especially spina bifida. So, remember here, what is the answer here? Related to Valproate, this question was asked. Okay, so in this manner, we have solved 7 questions of psychiatry, which were asked in recent INI CET exam. I hope you people have done a great job. Thank you so much.